ready to walk. शुरू क्या? शुरू. बच्चे खाते. My lady. बस मच्छर. ये सारा डाल ले. चलो. नको बा. मैं खा ली. अच्छा लोग.
मैम इसको फुल स्क्रीन कर दीजिए प्लीज.
Gunjana ma'am, should we start now?
Why Andrea like this space? पैरों की
और डोसा भी है अपन ब्रश करना है तो 15 सेकंड का करना है 15 से हाथ ही करना है ना मेरा
दोन मिनिटात का मिनिटानं
मिनिटाने दे 2 मिनिटात दे ना
What? Yeah.
Yeah, we got.
Hello. Hello. Dr. Kiran?
Good
Yes,
evening,
good
ma'am.
evening, ma'am.
Yeah.
Sorry.
Good evening.
I think you're asking for Dr. Kiran Suthar, right? Sorry. Hello, ma'am. This is Kiran here.
Yeah. Hi.
Sorry. I'll
So, okay. Shall we start?
Yes, ma'am.
Okay.
Good
So,
evening.
Dr. Kiran Suthar will be presenting a journal article today. I'll request Dr. Kiran to please start.
Yes, ma'am. Good. Thank you, ma'am. Good evening, everyone. I'll be presenting today's journal club, and moderator is our HOD, Dr. Sushma ma'am, and Dr. Gunjana Kumar, who is assistant professor in our department of neonatology, Lady Hardinge Medical College. So I'm presenting original research, that is umbilical cord milking in non-vigorous infants, that is MINVI trial, a cluster randomized crossover trial conducted by Dr. Anup C. Katheria, and it was conducted at 10 centers, 7 in US, 2 in Canada, and 1 in Poland. So it's a multi-centric trial. Why the study was planned? Basically, delayed umbilical cord clamping and umbilical cord milking. It leads to improved placental transfusion to vigorous baby. But this is not the case with non-vigorous babies because they need a immediate resuscitation. In that case, umbilical cord milking is an alternative as it can be performed more quickly than delayed cord clamping, and definitely it may confer some benefit. So the objective of the study is umbilical cord milking would reduce admission in NICUs compared with early cord clamping in non-vigorous newborns born between 35 to 42 weeks gestation, that is near term and term babies. This study was a pragmatic multicentric cluster crossover randomized trial in which 10 centers were included, as stated before, 7 in US, 2 in Canada, and 1 in Poland. And the infants born between 35 to 42 weeks gestation were recruited over the period of almost 1.5 years, that is January 2019 to May 21. The babies who were delivered between 35 to 42 week gestation and who were vigorous at birth were included in this study, and the assessment was done in first 15 seconds of birth and before cord clamping, and based on these 3 criteria, babies were termed as non-vigorous, that is poor tone, pallor, and lack of breathing despite initial resuscitation steps as per NRP guidelines. There were 8 exclusion criteria in which exclusion criteria. First one is major congenital and chromosomal anomalies in newborn, cardiac defects other than small VSDs. Things related to placenta are complete placental abruption or cutting through the placenta at the time of delivery, monochorionic multiples, cord anomalies like avulsion and true knots, presence of non-reducible nuchal cord, or the data which are not complete, and those delivered by obstetrician who are not trained as in this study protocol. So this is pictorial representation of what was done in MINVI trial, in which vigorous babies and those meeting the exclusion criteria were excluded, and non-vigorous babies were randomized by the center. And there was a crossover after the period of the designated period in which the study was done. And in the second half, there was a crossover. So this is how randomization and crossover was done. Initially, the obstetrician were trained for 6 months. Then randomization was done at the site. And the centers were labeled, 5 centers were labeled for early cord clamping and 5 for cord milking. And after 12 months, there was a crossover, and 1 to 2 months was a washout period. And again, then there was a crossover, and those first 5 centers, they were given this cord milking, and there was a swap. And then follow-up assessment was done at 6, 12, and 24 months, which is still going on. Then to minimize the selection bias, all deliveries that met the eligibility criteria were included for complete enumeration under a waiver of consent. And the outcome assessors were blinded and statistician also till the data was reported as group A and B until the data was logged. So the intervention done during this study, during the C-section, umbilical cord milking was done. And it was done as the baby was placed below the level of incision at the edge of the table or on a sterile blanket on mother's leg. And the second member milked the cord 4 times. But for the vaginal delivery, the infant is placed on mother's abdomen and the cord was milked 4 times, either by the obstetric care provider or the second member of the team. Then this umbilical cord milking, the cord for 20 centimeter was milked for 2 seconds, and this was repeated for 3 more times, leading to a total 4 in number. And for early cord clamping, the provider clamped the cord within 60 seconds of the birth. So the outcome was assessed as the primary outcome. The primary outcome is the admission in NICU for within the first 24 hours of the life based on a predefined criteria, that is respiratory distress, bradycardia or tachycardia, hypotonia, lethargy or difficult arousing, hypotonia or irritability, poor feeding or emesis, hypoglycemia, oxygen desaturation, cyanosis, apnea, convulsions or convulsion-like activity, hyperbil, and temperature instability. Secondary outcome was measured as need of therapeutic hypothermia, volume expanders, phototherapy, hemoglobin at 24 hours of life, and peak serum bilirubin. There are some exploratory outcomes also, like resuscitation interventions, blood pressure, and length of hospitalization. Sample size was calculated. That was 1200, and it was estimated to test the efficacy of umbilical cord clamping versus early cord clamping for the primary outcome on the basis of there should be a 35% relative reduction in NICU admission. That is 25% for early cord clamping and 16% for umbilical cord milking. This 25% for early cord clamping and 16% for umbilical cord clamping, there is no baseline data I could find in this study. Then analysis, how it was done. The primary analysis was intention to treat analysis. And for primary and secondary outcomes with adequate number, a generalized linear mixed model was used. Odds ratio and 95% confidence interval were estimated. For multinomial outcomes, 1 minute, like 1 minute and 5 minute Apgar score, multinomial logistic regression was used. And for all rare secondary binomial outcomes, a logistic regression was used. Coming to the results, these are a few baseline data related to mother, in which there is no significant difference in both the groups, like consent, delivery period, race, ethnicity. The only thing in which a difference was found was hypertension, which was significant. Number of mothers having hypertension is more in the umbilical cord milking group. Then coming to the neonatal baseline characteristics, there was no significant difference in race, ethnicity, mode of delivery, location of infant during cord treatment, gestation, sex, birth weight, the criteria for labeling non-vigorous babies, breathing or crying before clamping. Most of the babies were treated as per protocol. All the babies, this umbilical cord milking was done 4 times. Clamping time was 29 seconds in umbilical cord milking, and it was 20 in early cord clamping. Average clamping time was clamping time was less than 60 seconds in almost all the patients. Then coming to the primary outcome, there was the NICU admission as per predefined criteria, crude odds ratio. There was around 23% reduction in umbilical cord clamping, but when it was accounted for the study design, it was not significant. And there was no significant difference in all the predefined criteria in both the groups. Coming to intervention, there was around 36% reduction in cardiorespiratory support in umbilical cord milking group, and there was reduction of 43% requiring therapeutic hypothermia in umbilical cord milking. Otherwise, requirement of volume support and phototherapy, there was no significant difference. Then, though the number of babies born with moderate to severe HI were very less in number, but there was a significant reduction in those with umbilical cord milking. The rest, there was no difference. Then coming to Apgar score at 1 minute less than 1 minute less than 3, there was 21% reduction in those with umbilical cord milking. But again, in the next line in which 0 to 3 is written, there is no significant difference. It is mentioned. I could not find why this 2 things are given here as separate entities. And there is no any such explanation given in the paper also. Coming to the secondary outcomes, there was a 0.6 increase in hemoglobin in those with umbilical cord milking. Rest all parameters like bilirubin, mean BP, length of hospitalization, there was no significant difference. These are the results in a nutshell, in which there was no significant difference in reduction in NICU admission, but hemoglobin, requirement of respiratory support in HI, therapeutic hypothermia, Apgar score, there are differences. Now coming to the discussion, there are certain benefits of intact cord milking because it enhances the blood volume, which leads to a better neonatal outcome. In few studies done before, 4 cord milking leads to increase in 15 ml per kg blood, and 5 cord milking, it leads to 17 ml per kg increase in the total blood. And in our study also, we found that, in this study, there was an increase of hemoglobin as shown in these studies also. This umbilical cord milking, it provides a stimulatory effect by promoting earlier initiation of breathing, heart rate and tone by first minute of life. And it is depicted as the observed improvement in 1 minute Apgar and reduced need for cardiorespiratory intervention, oxygen administration, and positive pressure ventilation. And there are benefits of many other cells present, other things present in blood like fetal hemoglobin, progesterone. They are protective against the brain injury, and it is suggested by the lower incidence of moderate to severe HI and decreased need for therapeutic hypothermia. Though serum bilirubin was increased in umbilical cord milking infants, but it is not associated with any increased requirement of phototherapy. So it was sort of inferred that bilirubin is an abundant antioxidant in newborn, and it may be associated with improved neurodevelopmental outcome. This increase in blood volume leads to result in additional antioxidants and thereby improving the oxygen delivery to the organs that have suffered hypoxic injury. So this MINVI study infants are being followed up for 2-year neurodevelopmental outcomes, which is a pending result. So the strength of this study is it's a large multicentric study being done in non-vigorous infants, but there are certain limitations of the study. The first thing was blinding. Blinding would not be done for obstetricians and the patient to the assigned treatment arm. There was missing data because parents declined any data collection. And one more thing is there was a selection site bias. It was seen that lower delivery centers that were having less than 5,000 deliveries per year did not see a significant treatment effect. However, there was a significant difference that was observed with umbilical cord milking in large delivery hospitals, though the authors could not conclude why this happened. So coming to the conclusion, though the infants born near term or term, umbilical cord milking did not reduce NICU admission as per the predefined criteria, but there were certain benefits like higher hemoglobin, lesser delivery room cardiorespiratory support requirement. They had lesser incidence of moderate to severe HI, and they received less therapeutic hypothermia. So in umbilical cord milking in non-vigorous infants may be an important, affordable, easy, and potentially better practice. So this is the CASP checklist in which grossly all the entire content of checklist is almost met. Like they have given title, introduction, background, objectives, trial design. They have mentioned the eligibility criteria for participants also. They have mentioned proper intervention done at cluster level, individual level, and participant level. Outcomes are also very well defined, and the sample size, how they have calculated, they have mentioned it well. They mentioned the method used to generate the random allocation sequence. Then implementation is mentioned. They have given how they have implemented it well. And blinding, they have mentioned that they could not blind the caregivers and patients. Statistical methods they have explained well. Recruitment baseline data, number analyzed, they have mentioned. Outcomes, harms, there were no harms, they have mentioned it. So they have given the limitation and generalizability also. And they have interpreted the results considering all relevant evidences. Registration is being done. They have given a proper protocol and funding sources they have mentioned. So grossly all the criteria they have met. Thank you.
Okay. Thank you, Dr. Kiran. And we will open the journal that is presented for questions and discussion. So the first question in the chat is, was the randomization done prior to delivery or after delivery?
Should I answer, ma'am?
Yeah, of course.
The thing is, we cannot randomize a baby after delivery. So how they have randomizes, they have chosen a method known as crossover randomization, in which they selected these 10 sites and they were divided into groups of 2, that is 5 centers. So initially, they have given those 5 centers that you have to do umbilical cord milking for all the non-vigorous babies, and then the other 5 centers, they have to do this early cord clamping. And then after a period of 1 month, when all the numbers were enrolled, the mentioned number were enrolled, they crossed over. Like those centers who were doing this umbilical cord milking, they have to do now early cord clamping, and those who were doing early cord clamping, they were doing this umbilical cord milking. Got my point?
All right, so I think this is clear. crossover. So another question is crossover twice. Can you elaborate? Is it right to do? So I think it is not crossover twice. It is first you do one, and after a period of washout, you are doing the other method. So it's not repeatedly crossed over. It is only once. That first time you are doing milking, the next time around you are doing, umbilical cord clamping, which is immediate, or early cord clamping. Again, the question is randomization was done prior to delivery or after. So please understand, as she has explained, one center was to do all the cases which were born as non-vigorous. They have to follow only one protocol. Okay, so all babies who are born, they will do umbilical cord milking till the specified number has been reached. Then they will stop there. After a month of washout, they are trained to now do only early cord clamping, and which was done. So it is not waiting for the baby to deliver or not deliver, and it is they already know as soon as the baby is born, you see that the baby is non-vigorous, and you follow whatever is your center's code for that particular phase. I hope it is clear. Again, the same question, if it is before delivery, isn't it bias? So no, there would not be a bias. It is pre-specified that you have to do only, let's say, umbilical cord milking. So all babies who are born vigorous, they are out. All babies who are born non-vigorous and meet exclusion criteria, they are out. Only those who are born non-vigorous and meet the inclusion criteria, they will get into the arm that is for that particular center. So I think continuing with this, another question is, there might be bias due to the rate of deliveries at that center. So I'm sure they would have tried to balance the centers in a manner that when they are looking at a pair of two centers which were to cross over, they might have similar demographics in terms of number of deliveries, etc. So which they have not mentioned in the paper, but I'm sure before they decide which centers to take, they might have looked at this aspect. Although in their results, they found that those which had lower rates of delivery didn't have much difference in terms of NICU admission and all the other outcomes. And those who had higher rates, more than 5,000, they found that there was better. I mean, the number of NICU admissions were actually reduced, but even they have not been able to, speculate as to why this observation is there. So there's another interesting query that has come up. Would milking have an impact on cord blood ABG and so hypothermia criteria? So I'm not sure what is meant here, that would milking cause the blood gas parameters to go more acidotic, the pH to become more acidotic, or is it the other way around? But yes, this is an interesting question, that would it impact the cord blood ABG values? So I'm not sure if anybody has an answer or anybody has looked at that. So another question, why 35 weeker? Why not 32 weeks? UCM related IVH is more in less than 32 weeks. Yeah, sure, Dr. Vijay Kumar, that if we were to design, or if you were to design, we might look at some other, gestation as a cutoff. But the authors have designed 35 weeks, and I don't think anybody has asked them why they designed for 35 to 42 weeks. So probably they are looking at non-vigorous babies and are wanting to look at umbilical cord milking in that group. So that itself is novel in its own way, because till now cord milking was being done. This was one of the options. So this is being used here. Further to this, maybe somebody can try for smaller babies as a study, not as a clinical implementation, but as a study. Yeah, so any more questions? Anyone has any comment to make If there are, I mean, there may not be a question, but some comment to make. So there's a question, were the rate of deliveries at each particular center itself similar during the two different design periods? So actually it is not two different design periods. The period is like something like 2.5 years, 2 years and 5 months to be precise. So from 1 year, January of 2019 to May of 2021. So it's like 2.5 years, or let's say 2 years, 5 months. So for a period, they continued in one direction. After that, there was a wait or a washout period for a month to 2 months when the people were trained for the other mode to be used, and then the rest of the period followed. So I'm not sure if the authors have mentioned deliveries during phase 1 and phase 2. Kiran, you could let us know if that has been mentioned.
No, ma'am.
Or it is just the cumulative total in each group that has been mentioned.
Yes, ma'am. In each group, it's cumulative.
Mhm. So, I mean, one more thing can be that if we have any kind of queries, we could actually write to the corresponding author as an individual, and we may get answers from them. So something similar has happened with me when we had published the early total enteral feeding. I did get a lot of mails asking some of the aspects. So email is a way that we can write to. We may not write to the journal per se, but we can write to the author, the corresponding author, and they would be, I think they would be happy to respond.
Madam, good evening. Mangalabadi here. Can I just make a comment?
Sure, Mangla. Yeah, go ahead.
Good evening, everyone. Congratulations at the outset to the presenter. So it was a very lucid presentation. Really a good study with large numbers, and without any special device, they were able to implement cord milking even in non-vigorous babies. I'm just curious about two things in this study. The number one is that the choice of the primary outcome. I think hardly I'm aware of actually studies which had evaluated placental transfusion strategies where an outcome like the admission to an NICU is taken as the primary outcome. Though they have given some list of definitions for admission criteria, I just wonder how applicable, what will be the generalizability or usefulness of this one. It still looks like the primary outcome maybe subjective, because so many people could that be one reason why they were not able to show a difference? Just a comment on the choice of this primary outcome. That's number one. The second comment and query will be on they had shown a rise in hemoglobin. If I'm right, it's around 0.6 grams difference between 0.6 grams.
Yeah, 0.6 grams.
But if as per the data shown, if milking even by 4 or 5 times is going to result in something like 15%, around 15 to somewhere plus or minus 2 or 3% increase ml per kg, 15 ml to 17 ml per
15
kg.
ml, yeah.
But that should contain a significant more amount of hemoglobin, right? Even if you take the whole volume of a baby, these are all bigger babies, their volume may be somewhere around say 80 ml per kg at the maximum. Even if you take it as 100 ml per kg, if 15 ml per kg had transfused, that means 15% of their whole blood. So that should contain a lot more hemoglobin, not just 0.6 grams, even if you calculate in terms of percentages. Just like to have comments and views on these two issues.
Yeah, so the Kiran, do you want to respond?
No, ma'am.
Okay. So yeah, Mangla, the first one, even when we were going through this, so that was something, because although they have mentioned these are the criteria for admission, but that may be a little more subjective in terms of which babies get admitted or how many babies get admitted at a center. That's one. And second thing is direct effect of cord milking. Would be seen on cardiorespiratory stabilization or on HIE or something like that, or maybe even Apgar scores, the immediate cardiorespiratory stabilization. But admission per se, how does it translate into that being the primary outcome is something that hello. Yeah, so that is something that even, commonsensically, it would not occur to somebody doing a work on cause linking and looking at admissions. So, but the authors would know best why they have kept that as the criteria rather than any of, incidence of HI or incidence of severe HI or any of them.
Yeah.
So that was one. And the second one was, you said, sorry, I forgot.
The hemoglobin, ma'am. That looked like if that much ml kg got transfused, it should be more. The hemoglobin difference should be more.
Yeah, so logically thinking, yes, what you are saying makes sense, but they found it to be only 0.6 gram %. So, that's the hard thing that they have mentioned. This is what they
My
found.
only concern is that does that reflect a poor plasma transfusion despite this intervention? Could that be a reason for the no difference between the groups?
If they had done something like, what one of the initial person in this area had done, where they had weighed the baby. So when they had weighed the baby after, that wasn't milking, of course.